Hello, everyone, and welcome. My name is Linda Storm. I think you know who I am right now. And welcome to this presentation that is titled, Welcome to My Therapy Practices. I chose to use the metaphor of my real therapy practice to present my psychodynamic work, to explain my version of neo-psychodynamic. So I identify as neo-psychodynamic, trauma-informed, pluralistic therapist. No, that's a mouthful. And my foundation rests on common factors theory. And this allows me to work authentically and relationally with each client using and not limited to EMDR, hypnotherapy, talk therapies, with a whole lot of parts work. I hold certifications in narrative therapy advanced, clinical hypnotherapy at a master's level, and recently EMDR full certification. So I take these structures very seriously, and I will explain later that psychodynamic work sometimes feels like it's without structure, but that's not true. But when we start to pull in from various modalities or techniques or functional structures, it's really important that we know where it comes from. So when we apply it appropriately within a structured framework. So my work is informed by relational depth, flexibility with neurobiological safety. My clients are often navigating complex trauma histories, and they come with very high levels of anxiety and depression that they've been holding for quite a long time, if not from childhood. And we work through the complex trauma and histories, living on a neurodiverse platform because they are neurodiverse individuals living in a very neurotypical world that has not adapted to them. And theoretical orientation allows me to respond to their needs in a moment while maintaining coherence in that therapeutic depth. So, with that in mind, take a deep breath and we will move into our agenda. Now, I have formulated this so that you can sit and relax and listen. So, if you want to hit the pause button right now, please do. Hit the pause button, put on some earphones, sit back, relax, the big pillow or a chair in the sun or lay in the grass and just sit and listen. You will miss nothing, I promise. As I work through the next 15 slides, I'm going to do a countdown. So you will know when each slide is presented and you can create your own image in your mind based on my words. Those of you who choose to hang in and listen to me here, you can do that, but you will be looking at the same slide for quite a long period of time because I put my effort into my narration as opposed to the actual presentation itself. So with that in mind, I'm going to move to the first slide, which is slide, and I'll actually say slide 3 of 17 and the name of the slide so you can visualize it. And as you visualize that, every time I introduce a new slide, just take a nice deep breath through the nose and just let it out gently through the mouth. And with every slide, you're just going to get deeper and deeper relaxed because you're going to be able to just swoon in the relaxation and just listen to the words. Okay, let's start with slide 3 of 17. Why I moved away from models. I moved away from protocol-bound models over a period of time because many of my clients, especially those who are neurodivergent, felt harmed by inflexible therapeutic systems. I've learned from my clients that healing happens in a relational space, not in the application of the techniques. I'm talking about those common factor integrations that we've talked so much about over the last few weeks. As a matter of fact, one client, for example, had previously been through what I call a manualized trauma program. It was very DBT based. I love DBT, but had never been asked how she experienced her body over a period of 11 sessions. Not once. How did she experience that during her sessions in her body? When we used part works and body work and some somatic work and some hypnotherapy instead, she was finally able to feel a sense of agency and internal safety for the first time and trust her body, trust the body that she was very interested in understanding. So, slide 4 of 17, theoretical pillars. My approach is grounded in common factors theory. That connection, called the therapeutic relationship, is my main focus. Right from the beginning, right from the first glance, right from the first lean forward, right from the first handshake or the first telephone call, even the first email. This means I focus on the therapeutic relationship. Shared goals and client engagement are the real agents of change that grow out of this. So research affirms that the how of therapy often matters, but it's less than the who the therapist is and how we connect. My interventions draw from a very grounded toolkit, but what guides them is the mutual understanding between myself and my client and what we're going to do and how we're going to do it next. It's very interesting, particularly in the world of neurodivergent, how sensitive they are to different things. And when you've met one client with neurodivergence, our constellation and their cluster of symptoms and traits are truly unique. You really can't generalize anything from that to another client. There's no concept of templating. Everybody is unique. So every intervention is unique and every combination is unique. So slide 4 of 17, just take another deep breath. The theoretical pillars. As I mentioned, my approach is absolutely grounded in common factors theory. It means I focus on the therapeutic relationship and I practice on top of that therapeutic relationship using the techniques of EMDR, parts work, talk therapy, hypnotherapy, narrative therapy, and a lot of borrowing of what I call the mini tools, the singular tools from CBT, solution focused, IFS, and various works of that nature. So, slide 5 of 17, the assumptions. I believe that my clients are wise. I see healing as inherently rational and relational. Neuroscience supports this. Our brains are plastic, they're adaptive, and they are wired for connection. I am a very big component of the concept that neurodiverse individuals are not, it's not a model of deficits, as the DSM may imply. It's a model of differences. And differences are not necessarily bad. Differences sometimes are what makes them extremely functional in some areas, which we call multiple intelligences. If you can actually look at a population base, which is where a lot of our evidence-based science comes from, it comes in the form of a Let's visualize a bell curve as your neurotypical being in that 65% range. And then there are people who are off the charts on one end, and of course, they're off the charts on the other end. So in neurodivergent work, you will notice that they don't always fit right on that bell curve, that they're either extremely to the right or they're extremely to the left. They have various models that are emerging right now, which is known as the monotropic thinking model, as opposed to the polytropic thinking model. Whereas a polytropic thinker would think more inside the bell curve, whereas a monotropic thinker would have a little bit of thought processes operating on the outside. A really beautiful example of multiple intelligences would be, and this is an extreme example, this is not always the example, would be individuals like Einstein. And Einstein had multiple intelligences. He was just off the charts as far as mathematics, sciences, and physics went. But on the other side of the chart, he required a lot of guidance, or he chose not to refine those skills, whether it be a choice or whether it be selective blindness or whether it be actual blindness, is not what we go for. We just notice where that individual wants to sit and where they are happy and where they're comfortable, and we work with that. We do not try to push them into the bell curve to be very, very timid. So one autistic client once told me that for the first time they didn't have to mask in therapy. That shift happened because I slowed my pacing. I reduced the visual load because I noticed the visual load was very much problematic. And I used storytelling and metaphors, tools that supported their neurobiology rather than challenge it. Very important. So now let's move to slide 6 of 17. My therapeutic tools, my choice of therapeutic tools. I use EMDR when trauma loops and dominates the client's nervous system. For example, one client relieved and actually just had walked out of a very severe car accident, and they lived it daily, PTSD, in their mind. Through EMDR, we were able to reprocess the fear and reconnect with a sense of safety for driving. It was the client's choice to remain driving. We carefully explored whether driving was in their future or whether driving was not in their future. Once it's established and they decide driving is in their future, we progressed. And then I used hypnotherapy, or we used hypnotherapy, when we needed a deeper connection to the internal imagery of what it would be like to drive again with peaceful confidence, or when any verbal processing is difficult. Describe what they're feeling. So it's very interesting how we navigate the paths of what the client wants and what the client needs. Another example is when a client needs a deeper connection to an internal imagery, a past event, which may be brought to them by PTSD, or when verbal processing is difficult, like a client with selective mutism, which could be a coping mechanism, which could be a resistant mechanism. We bring them as a part to the therapy, holding space for those parts within a client that need containment, reflective dialogue, and insight. I don't assume integration. I don't assume the parts want to become one. Sometimes we celebrate and we maintain the parts as separate pieces. That's a client decision. Parts work is often integrated throughout what I do. For example, when a client experiences a conflict between the productive self and the grieving self, we explore and mediate those parts as we uncover the meaning slowly. I often integrate the tools within a single session. particularly during longer sessions. My sessions span generally for this kind of work way longer than your traditional historic 40 to 60 minute session. My sessions span 90 minutes to 2 hours, and they don't come every week. They come every second or third week because they find it too much to do every week. And it's too much mentally, and it's too hard on the pocketbook. We have to actually integrate reality into these sessions as well to come up with a sustainable level of participation with the client. For example, a session might begin with a narrative talk therapy and resourcing. We move into EMDR targeting, but what a lot of people don't realize is that EMDR is not only used to unravel traumas, it's not only to unravel those pre-programmed conditioned responses in combination with hypnotherapy, it's also allowing a client to go on what I call the peaceful confidence tour. I call it the peaceful confidence tour because we look and we find that place of safety. Where does the person hold that place of safety? Because that place of safety is where they can always go back to should they start to tap a little too far through that therapeutic window. We don't want when during trauma sessions we want to revive, we want to revivicate, we want to go there, but we want to be there in the present. We don't want to bring the client to a stage where they are reviving the memory and they are dissociating 100% as the child who was abused or as the adult who experienced the traumatic event. We want to make sure that they see it from the present. They have to know from the present. So we work from the safety to the revivification and then back to the safety into the present. Very important concepts. And for that, we need a complex toolkit. For example, a session, that same session that spans 90 minutes to 2 hours might begin with narrative talk therapy, the story, so that we can get a handle on the negative core value or the speak or the fear and the resourcing. Then we move into resourcing. Then we move into targeting. And we may end with a brief hypnotic metaphor for grounding. This layered use of modality reflects the complexity that we're dealing with as therapists every day with complex clients and the capacity of my clients' inner worlds to be able to accept that work, to support that kind of depth-oriented integration. I do prefer depth over structure. I will move slower to go deeper as opposed to move through a structure in a very time frame. If it takes 2 or 3 sessions to process one event, if it takes 20 sessions to process one event, we take one event, but we go deep and we test it at the end and we make sure it's sustainable, but we always stay within the window. We have to push the window or we don't make any headway, but we certainly don't want to exceed the window. So slide 7 of 15, a clinical example. EMDR. I worked with a client experienced hyperarousal and fragmented trauma memories all over the place. We used EMDR to target sensory activation and reconnect to a coherent narrative. So what I'm saying there is we worked on it from a somatic perspective. The hyperarousal, the trauma memories were so fragmented. I didn't know if I was dealing with feeder memories. I didn't know if I was dealing with multiple memories. All we knew is that the hyperarousal was very large. As we know, the body talks. So let's listen to the body. We managed to map the feeling where it lived in the body. We gave it shape, we gave it color, we gave it a narrative that the client could refer to forever. I didn't name it, the client named it, the client described it. And it was interesting in how we literally chased it from where it originally was the strongest, which was the size of a big, bright orange baseball in about the vagus nerve area, which makes very sense. It dropped to nausea. We continued and we were persistent because I was going for the total disintegration or the dissolving of the feeling. And then it went up into the throat, and then it went into the shoulders, and then it went back into the chest or into the very vagus nerve area before we finally got what we call a subjective unit of distress from about 8 all the way down to a 1. We never got a 0. But when I said, what is the difference between 1 and a 0? And basically it was, I need to work with it. I need to work with it for over the next week or two and see if I can hold this sense of safety without walking around with this fear baseball living in my chest without flashbacks. And it wasn't just about reducing flashbacks, it was about reprocessing at an identity level, reverse engineering from the feels back to the memories that had never been named. The client reported being able to finally feel safe walking into a grocery store without shutting down. We also learned through the narrative that it was repeated behavior and being punished whenever being in a public space, which for a young person was an outing, going shopping with the parents. And we learned to quiesce and we learned to quiet that part of the self. But it was the feel that brought us to the memory, to the healing. We also use narrative tracking between sessions to support integration. How are you doing now? Because sometimes I don't see clients for 2 to 3 weeks as they work through it, but I want to make sure they're supported through it. So let's go to slide 8 of 15. Clinical example of hypnotherapy. In another case, a client who shut down verbally responded well to hypnotic storytelling. This took a while, about 3 or 4 sessions, and anxiety was very, very high. So doing one of our peaceful confidence tours, we discovered by going through the memory and dropping down to an alpha theta stage that storytelling was the key. This is how this individual thought. They described feeling frozen in previous therapy. Frozen. What I mean by frozen was not cold. What I meant was frozen. This was very interesting. The person was right in front of me in the office. This wasn't a remote session, but we've all experienced a freeze in a Zoom where it just is freezing. And you're wondering at this particular point, is it the technology or is it the person? This person in front of me just froze and stared into a corner. And of course, being uncomfortable with just sitting and being quiet is one thing, but being comfortable with a person freezing in front of you is quite another. So you're looking for things like an eye blink, none. You're looking for breath. Yes, there's breathing. And you're looking for motion. There is no motion. So what's going on here? And just to give you a little bit of background in this little clinical example, this is a client who was in about session 8 or 9. And this client knew that when we do EMDR, when he goes into this freeze, that I will just gently roll up and start EMDR tapping on the outside of his knees, just ever so gently, ever so gently. And I will wait a good minute, minute and a half, maybe 2 minutes before I start that. Because while he's frozen, he is reflecting and he is thinking, but he freezes. The reason I tap is to make sure that we don't disassociate totally and that we can bring to the present. which is the now. You are here. You are safe. You are with me. You are in this therapy room. We are together. And I just very gently will bring back. I will say nothing. I will do nothing, but I will gently tap the sides of knees. And eventually the unfreezing occurs. And when he emerges, it comes out with usually something very prolific, or something for the first time, realizing where it came from. In this case, it was, now I get it. Every time my parents did that, it was a message to me that I wasn't safe, that I couldn't talk, that I couldn't do anything, because then I would be punished, and it would be horrible punishment. So I would just do nothing. And that translated into fear, which translated into a very overemphasized freeze. But it gave them a way to reconnect and understand it and bring that out themselves. So that was a clinical example of hypnotherapy coming out using EMDR. Because usually I use EMDR to induce into hypnotherapy, because it's very interesting trying to do an induction with somebody who's on the spectrum, or bringing them out so that they're present. Okay, so the next slide is another clinical example. We've gone through a clinical example of EMDR, clinical example of hypnotherapy. Now slide 9 of 15 is the clinical example of how I may use talk therapy. Example, of course. Talk therapy supported a client who has been masking for years. Together, we explored identity fatigue, relational ruptures, and the pain of not being seen. Or we stand corrected, the pain of not being seen them for their authentic self. In talk therapy, I use psychodynamic methods to slow down the thought patterns and to examine the client's relational templates. Meaning, what is it that they're truly thinking about what they're supposed to be doing? We traced a pattern from childhood, going back to, I must not be too much. Well, guess what? Without telling you, I must not be too much is a parent that had a very low tolerance for hyperactivity, ADHD. And this leads out to current workplace burnout. The unmasking began in our sessions and gradually extended to chosen family members and colleagues. Being able to unmask in a safety place at work was easier than eventually learning to unmask with family members and finally their colleagues. And it was very interesting to watch that. I was very, very curious to how that pattern unfolded. I must not be too much was a culmination of developed persona in being overly vivacious from a personality perspective, seeking attention, to being quiet at the wrong time. That are the words directly from my client. Not wanting to remove either of those behaviors, but being able to dial one up and dial one down to meet societal norms. And here's an example of a client who had come to me finally thinking, you know what? I don't think I'm bipolar. I believe that I am just on the spectrum. I have received so many people who come in with labels, with diagnoses, and they're very confused. And I tend to shift that from being labeled to helping them externalize that and hopefully be able to understand the nature of those tools, that to label somebody All it is a way to fit you into a neurotypical system so that we can line you up for resources in some cases or not. It's not a punishment. Is it the best designed system in the world? It's not. But can we deal with it? We can when we understand it. So, slide 10 of 17, the therapist's role. My role is not to fix. As a neuropsychodynamic individual with all of these toolkits and all of these interesting things that come, my role is just to accompany. I attune to the client. I co-regulate with the client. If a rupture occurs, I lean in and I prioritize the repair. And I want to be very clear. Psychodynamic work is not without structure. Its structure lies in the therapeutic frame. The consistency of session timing, the disciplined attention to the unconscious processes and what they mean, being able to interpret them, being able to help the client interpret them and put them into words. And that's what CBT may call reframing, where you create a frame, the consistency of the session timing, what you do in the session, does it match well with the client? The disciplined attention to unconscious processes and the interpretation of the stance that remains rooted even amid complexity. And when all else fails, the one thing that generally reads correctly is the body. I mean, the real body feels. When I say, what does that feel like? And they give me an emotion, I have to very carefully unravel that and say, no, I want to know where you feel that. So creating a language for them that they understand is deeply important. Psychoeducation plays a big role in the work that I do. It is a deeply structured approach that attends to the inner patterns and relational dynamics over time. For example, when I use parts work within a psychodynamic frame, I pay very close attention to how each part relates to internalized caregivers and myself, and how the defense mechanisms and those resistance layers maintain psychic survival. I said that very, very quickly because those are not parts to throw aside. If it is a protective part, if it is a mechanism, its chances it's rooted in something that has to do with either psychic survival way back or physical survival way back, depending on the nature of the trauma and the various trauma. So those parts are welcome and we work with them. This is not an improvisation. It's a methodological, coherent, and reflective way of sorting out and dealing with very complex structures. And for us to be able to learn quickly, being taught by our clients what their language is and what their parts are. And to be able to not only befriend them, but develop a therapeutic relationship with each and every part. Okay. Slide 11 of 17. I just want to touch a little more on diversity and neurodivergence. Standard therapy often assumes a neurotypical clock and a linear logic path. What I'm referring to here in plain English is the traditional 50-minute session with a note at the end, and then another rebook at a later date, a little bit of homework in between. I'm going way beyond this. I challenge this by offering clients choices and pacing, not only pacing within a session, I'm talking about pacing across a session. I'm looking at each and every touch point, right from the note I get from Psychology Today to the final termination. And I have a few things to say about a termination as well. I consider that an entire conversation. I consider that the entire therapeutic journey, including little emails in between that says, I can make this, I can't make this, I'm doing this, because sometimes that's part of therapy. Their pacing, their engagement in therapy, for me, is part of the journey. And I note those things about that client, and they play a role. I also am going to challenge this concept of termination. I have a very open door policy, and what that means is I don't take just anybody and everybody because I'm not everybody's cup of tea. I get that. There's millions, thousands of different therapists out there. Find the one that works for you. This is how we're going to work together. Do we mesh? And as far as termination goes, we know when we've healed something, we celebrate and we note it. We will test it. We will make sure it's sustainable. I will make sure that there is enough coherence in the therapy that we've done that this person can now sustain this on their own, that they won't need me forever and a day. I am not enabling, but my door is open. My typical client, not all, my typical client will start with maybe once or twice per week, and then they'll go to once a week, then they'll go to once every 2 weeks, and then they'll go once every 3 weeks. And I have clients that have had forever and a day, and that's a metaphorical saying that we'll check in once every 6 months. They'll let me know what they're doing, or there might be something else that they have a query about that they're trying to work around. And because I have the complete backstory and I still hold their fundamental therapeutic trust, I'm there for them. They do not have to start with a new therapist, given the depth of the work we've done and the history that we have together. And I know this challenges some of the quasi therapeutical expectations, but it's something that I do, which pushes me into private practice. The other thing I'd like to mention as well is the relationship that I have with my clients. I read everything. I read everything between the lines that they do, including the frequency. It tells me a lot about where the client is at. And I don't let them struggle between sessions. I'm not an emergency service, but I don't let them struggle between. If I find they're struggling between sessions, that's what we work on. So they do not struggle. And we give them the efficacy and we give them the tools that they need to carry on and to build. The work reflects them. Slide 12 of 17. I would be remiss if we didn't talk about the strengths of the orientation. So slide 12 of 17 is strengths of my orientation. The approach is deeply adaptable. It allows me to meet people where they are. Often I'm not their first therapist. I'm very rarely anybody's first therapist, and I honor every minute they've invested in therapy before, and they have had some good therapy in. That allows us to move very quickly and to go very deeply. And I attend to what they need. It invites honest feedback and collaborative revision. Constant ongoing consent. There's the first consent to come into therapy, and then there's ongoing consent throughout therapy, minute by minute, as I weave in and out of EMDR and hypnotherapy. They know exactly what I'm doing, why we're doing it, while we're doing it, and I ask if we can do it, and I only do it if they're okay with it. It's like a shared inquiry and less like a procedure. One strength is that clients begin to take ownership of the process. Ah, I love that. And they come in saying, this week I want to work with that angry part again. Or can we go back into that image from the last session? And that's the kind of therapeutic engagement that fosters real change. I never make the assumption that the client is coming in to continue where we left off last time. It is my hope that they have done a lot of groundwork in between sessions. So it's more, where are we now? And that tells me a lot about what to do next. So now I got to talk about the limitations of this orientation that I carry. So slide 3 is limits of this orientation. The work is demanding, a lot of shadow work involved. I am not going to dismiss that. It asks me to be intellectually rigorous and emotionally present at all times. It also does not always align with systems that favor standardized outcomes and brief interventions. And that is where it gets a little difficult, and you actually have to manage it up For new therapists, the lack of the step-by-step manuals might feel disorienting, but the structure lives in the theory. The safety lives in the relationship, and the results live in the client's growing capacity for growth and being able to reduce anxiety and reduce depression and reduce trauma responses and start living a very beautiful life. It takes a while to understand the limitations of the orientation so that it remains with structure. If you were to open my notes, you would see I have a combination of handwritten notes. I have a combination of research, which is very pointedly gathered around a particular client or something that I'm working with. I have two supervisors, one that is really well versed in EMDR and hypnotherapy, and another one which is extremely well versed in psychodynamic work. I put the two together, and it's very interesting. And sometimes it comes together very good, sometimes it doesn't. So I'm a bridge for those two worlds, and I understand that. Slide 14 out of 17. Now we're getting to personal alignment. So slide 14 is I'm going to talk about my personal alignment. This work reflects who I am. I am endlessly curious, retired back in 2009. This is something I do because I love it. This is a labor of love, and it's a true interest of mine. In the process, I have developed a very interesting private practice, which some people call unique, which I personally wish wasn't unique. Throughout this process, I protect consent. I abide by relational ethics. Above all, my certifications continue. My depth of training is natural, including this program, and all of the information I take away daily from my peer group, which is you all. But my presence with my clients is what creates safety. I strive to embody coherence. My theory, my values, my methods all reflect one another, and my clients feel that. And they tell me that therapy with me feels like being invited to be themselves without condition, finally. And this goes to one of the things that Carl Rogers was trying to get us to understand, is that concept of unconditional positive regard. I would like to extend that thought now to say, hey, unconditional positive regard, is that just exclusive to clients, or is unconditional positive regard something that we need to turn outward to the world and to how we live our lives? I'm talking everything that has to do with neurotypical systems, capitalism, the way we work, social norms, political norms. Are they all truly being worked and viewed with unconditional positive regard? Something to think about. So now we're on slide 15 of 17. The concept of theoretical integrity in pluralism. Because pluralism is often misunderstood as disorganization, or the without structure part I was talking about before. But in reality, my pluralistic practice is structured by common factors. If it's a tool like EMDR, like hypnotherapy, or I'm pulling from SFTP, or I'm pulling something like laddering or reframing out of cognitive behavioral training, it's to put and to support the common factors theory. It's to support all of those things that is rooted in those common factors throughout therapy. And it's just simply rooted in a psychodynamic principles. It allows me to go unconscious. It allows me to think in different ways. And it allows the client to think and express in different ways and be with the total unconditional positive regard. I do not tell a client who has been sent to me with a diagnosis of schizophrenia, it's okay if you've been abducted by aliens. It's okay. You know what? I believe it. If it's thought in your mind, I believe it. Does it represent reality or does it represent something that really happened? Is it an abstract way of thinking and coping to deal with something that happened? Think about this. Here's just one more example I'm going to give you. A client who came to me clearly labeled as schizophrenic to the point where they were hearing physical voices, which were very loud, being abducted. Traced back eventually to, we don't know for sure. This is still out, but then again, I have to ask you, does it matter? A car ride as a 10-year-old on the way to what looked like an army facility. We heavily suspect there was a lot of chemicals and drugging involved in these children. What does your mind remember of an experience when it's on psychedelics? Okay, where do you go with that? If that's what the client remembers, it's real. So you have to remember and have a basic understanding of how you're going to go very deep so that you can unwind that chaos. And eventually you will find out that it reflects who they are and what they need. This is not chaos. This is depth informed flexibility to be able to go in and do that. Are they schizophrenic? Does that matter? Or does making them feel better and getting them to come to grips with it as a deep, unique trauma? Is that what matters? Slide 16 of 17, resources. There are core resources that support my practice. A lot of colleagues support my practice. And I work from personally a very solid social justice perspective. I agree that the meta-analysis on outcome predictors is the ultimate deciding factor on whether or not you're helping people or not. And of course, the people that you help. These help ensure that my practice is not just experiential or experimental, it is research-based and ethically grounded. I always stay close to my resources. And that's one of the reasons not only do I enjoy, but I need that second, that third opinion, thus 2 different supervisors. So my closing reflections, slide 17 of 17. Here we go. I brought together a list of references that reflect my practice. Healing cannot be standardized, and therapy should not be sanitized of its relational embodied impact, which means clients are complex, they're intelligent, and they are unique. They deserve therapy that reflects them. This presentation was not just about my orientation, it's about an invitation to consider the depth over structure, diversity and understanding, and the dialogue as its core relationship to healing. So thank you for walking with me, and my last 3 pages of my presentations are a set of carefully chosen references that I use to build this presentation. So thank you very much. I end.